colon and rectum. Question and answer session. Welcome to today's podcast, where we discuss the main aspects of surgical management of benign pathologies of the colon and rectum. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the surgical management of benign pathologies of the colon and rectum. Pause the podcast after each question to attempt answer. Let's begin. Inflammatory bowel disease epidemiology and etiology. Question: what is the global prevalence pattern of inflammatory bowel disease? Answer: inflammatory bowel disease is primarily considered a disease of Western countries, but its incidence is rising in Asian countries that are adopting Western dietary habits. Question: which region has the highest prevalence of inflammatory bowel disease, and where is Crohn's disease most commonly diagnosed? Answer: Europe has the highest prevalence of inflammatory bowel disease, while the United States reports the highest incidence of Crohn's disease. Question: what are the main risk factors associated with the development of inflammatory bowel disease? Answer: A genetic predisposition is significant, with over 10% of patients reporting a family history. Environmental contributors, such as cigarette smoking and the use of antibiotics, are also linked to the development of inflammatory bowel disease. Disease distribution and classification. Question: how is ulcerative colitis classified according to the extent of inflammation? Answer: ulcerative colitis is graded based on the extent of inflammation within the colon. Question: what are the possible anatomical locations for inflammation in ulcerative colitis? Answer: inflammation in ulcerative colitis can be limited to the rectum and sigmoid colon, restricted to the left side of the colon, or extend to involve the entire colon. Question: what are the main types of ulcerative colitis based on disease location? Answer: the main types include proctitis, proctosigmoiditis, left-sided colitis, and pancolitis. Question: what classification schemes are commonly used for Crohn's disease? Answer: the Vienna classification and the Montreal classification are widely used to classify Crohn's disease. Question: what criteria are used in the classification of Crohn's disease? Answer: classification is based on age of onset, the location of bowel involvement, and the behavior of the disease. Question: what additional factors were introduced in the Montreal classification for Crohn's disease? Answer: the Montreal classification subdivides age of onset into less than 20 or greater than 20 years, and includes perianal Crohn's disease as a classification criterion. Question: how is Crohn's disease behavior further classified? Answer: Crohn's disease behavior is classified into inflammatory, fibrostenotic, and fistulizing types. Question: how does the progression of Crohn's disease typically occur? Answer: inflammatory Crohn's disease may progress to fibrostenotic disease, which can result in intestinal obstruction, perforation, abscess formation, and fistula development. Question: what is the primary treatment goal in managing Crohn's disease? Answer: the main goal is to interrupt the progression of the disease in order to prevent complications and the need for surgery. Clinical presentation and disease diagnosis. Question: what are the common symptoms observed in both ulcerative colitis and Crohn's disease? Answer: both diseases may present with diarrhea, although it is typically more frequent and severe in ulcerative colitis, and is often accompanied by bloody stools. Question: what symptoms help distinguish ulcerative colitis from Crohn's disease? Answer: ulcerative colitis often presents with tenesmus, urgency, and anemia, whereas Crohn's disease may present with abdominal pain, a palpable mass in the abdomen, or perianal disease. Question: what perianal manifestations can occur in Crohn's disease? Answer: Crohn's disease may cause perianal complications such as painless and atypical anal fissures, anal skin tags, anorectal abscesses, fistulas, and anal stenosis. Question: how prevalent are extraintestinal manifestations in patients with inflammatory bowel disease? Answer: up to half of patients with inflammatory bowel disease experience extraintestinal manifestations, with approximately 24% exhibiting at least one joint, ocular, or skin manifestation. Question: what is the most common extraintestinal manifestation of inflammatory bowel disease? Answer: arthritis, particularly sacroiliitis, is the most frequent extraintestinal manifestation. Question: what is the clinical significance of ankylosing spondylitis in inflammatory bowel disease? Answer: ankylosing spondylitis is a serious joint manifestation that can complicate intubation and requires special preoperative anesthesia assessment. Question: What are the main cutaneous manifestations of inflammatory bowel disease? Answer. Erythema nodosum and pyoderma gangrenosum are the primary skin manifestations. Question. How does pyoderma gangrenosum present in patients with inflammatory bowel disease? Answer. Pyoderma gangrenosum presents as painful, ulcerating skin lesions, often developing at trauma sites such as surgical incisions or stomas. Question. What are the features and treatment response of erythema nodosum in inflammatory bowel disease? Answer. Erythema nodosum appears as red, painful, swollen nodules and typically responds to systemic steroid therapy. Question. Why is non-operative management preferred for pathergy in inflammatory bowel disease? Answer. Non-operative treatment is preferred because surgical manipulation can worsen the condition. Question. What non-operative treatment options are available for cutaneous manifestations of inflammatory bowel disease? Answer. Treatments include intralesional steroid injections such as triamcinolone, topical tacrolimus, or systemic biologic therapy targeting tumor necrosis factor. Question. What is the typical outcome of treating cutaneous manifestations of inflammatory bowel disease? Answer. Treatment usually leads to a resolution of symptoms. Question. What ocular manifestations are seen in ulcerative colitis? Answer. Ocular manifestations include uveitis, iritis, and episcleritis. Question. What complications can arise from ocular involvement in ulcerative colitis? Answer. These conditions can cause significant irritation and often require referral to an ophthalmologist. Question. How common is sclerosing cholangitis among patients with inflammatory bowel disease? Answer. Sclerosing cholangitis affects approximately 2.16% of patients with inflammatory bowel disease, with varying prevalence in ulcerative colitis, Crohn's disease, and unclassified cases. Question. What is the natural course of sclerosing cholangitis in relation to inflammatory bowel disease? Answer. The course of sclerosing cholangitis is independent of inflammatory bowel disease and can progress to cirrhosis, liver failure, and may require liver transplantation. Question. What additional risks are associated with sclerosing cholangitis in inflammatory bowel disease patients? Answer. These patients have an increased risk of developing colorectal neoplasia and pouchitis. Disease diagnosis. Question. What diagnostic method is considered the standard for inflammatory bowel disease? Answer. Endoscopy, including rigid proctoscopy, flexible sigmoidoscopy, or colonoscopy, is the standard diagnostic method. Question. What is the purpose of colonoscopy in the evaluation of inflammatory bowel disease? Answer. Colonoscopy is used to assess the extent of disease and to examine the terminal ileum. Question. How do the endoscopic patterns of inflammation differ between ulcerative colitis and Crohn's disease? Answer. In ulcerative colitis, inflammation begins at the dentate line and spreads upward, whereas in Crohn's disease, inflammation is patchy with skip areas. Question. What are the characteristic endoscopic findings in ulcerative colitis? Answer. Ulcerative colitis is characterized by a roughened or granular mucosa, with severity graded by the Mayo Clinic scoring system based on the degree of ulceration and bleeding. Question. How does increasing severity of ulcerative colitis manifest endoscopically? Answer. Greater severity is associated with a more erythematous mucosa and progressive ulceration. Question. What are the endoscopic features of Crohn's disease? Answer. Crohn's disease is characterized by deep, punched-out ulcers, often with serpiginous patterns and fibrin coating. Question. Where are ulcers most commonly found in Crohn's disease? Answer. Ulcers are most commonly located on the mesenteric side of the bowel. Question. What are the most frequent sites of involvement in Crohn's disease? Answer. The most common site is the ileocolic region, followed by the colon, small intestine, and upper gastrointestinal tract. Question. What are the key histological features of ulcerative colitis? Answer. Ulcerative colitis shows significant inflammation with polymorphonuclear leukocytes, mucin depletion, and crypt abscesses. Question. How is the inflammatory process in ulcerative colitis limited anatomically? Answer. Inflammation is restricted to the surface epithelium and confined to the large intestine. Question. What is the disease distribution pattern in ulcerative colitis? Answer. The disease demonstrates continuous involvement of the colon without skip lesions and lacks transmural complications. Question. What are the defining histologic features of Crohn's disease? Answer. Crohn's disease is characterized by transmural inflammation and the presence of non-caseating granulomas in approximately 1/3 of patients. Question: How is Crohn's disease confirmed histologically? Answer: Confirmation requires identification of non-necrotizing granulomas or transmural lymphoid aggregates in areas that are not deeply ulcerated. Question: What conditions must be considered in the differential diagnosis of inflammatory bowel disease? Answer: Infectious colitis and drug-induced colitis are commonly considered in the differential diagnosis, especially in biopsy reports. Question: What is the definition of undetermined inflammatory bowel disease? Answer: It refers to a subset of patients who exhibit characteristics of both Crohn's disease and ulcerative colitis. Question: What is the estimated prevalence of undetermined inflammatory bowel disease? Answer: It is estimated to affect 10 to 15% of patients with inflammatory bowel disease. Question: How is a diagnosis of undetermined inflammatory bowel disease made? Answer: The diagnosis is made when uncertainty remains after examining a colectomy specimen that displays histologic features of both Crohn's disease and ulcerative colitis. Medical treatment. Question: How has the philosophy of medical treatment for inflammatory bowel disease changed over time? Answer: There has been a shift from a bottom-up approach, starting with the safest and least expensive medications, to a top-down approach using stronger, more potent medications initially. Question: What are the drawbacks of the top-down approach in inflammatory bowel disease treatment? Answer: The top-down approach involves medications with higher side effect profiles, greater costs, and an increased risk of post-operative complications and reactivation of remote infections. Question: What medications are commonly used in the treatment of inflammatory bowel disease today? Answer: A variety of medications are used, including those for rheumatoid arthritis and psoriasis, with increasing application in inflammatory bowel disease. Question: What were the main medications used for inflammatory bowel disease before the introduction of biologic therapies? Answer: Sulfasalazine and steroids were the primary medications previously used for inflammatory bowel disease. Question: How has the introduction of biologic therapy changed the treatment landscape for inflammatory bowel disease? Answer: The introduction of biologic therapy over the past 25 years has revolutionized the management of inflammatory bowel disease. Question: What is the primary mechanism of action for most biologic therapies used in inflammatory bowel disease? Answer: Most biologic therapies are based on antibodies directed against tumor necrosis factor alpha. Question: What was the first tumor necrosis factor inhibitor approved for Crohn's disease, and when was it approved? Answer: Infliximab, a chimeric anti-tumor necrosis factor antibody, was the first approved in 1998. Question: When was the first Janus kinase inhibitor approved for ulcerative colitis, and what is its name? Answer: Tofacitinib was approved for ulcerative colitis in 2018. Question: What is the most recent drug approved for inflammatory bowel disease, and what is its mechanism of action? Answer: Risankizumab, a human monoclonal antibody targeting the page 19 subunit of interleukin-23, was approved in 2024. Question: What is the current approach to the use of medications for inflammatory bowel disease? Answer: There is now a wide variety of medications available for the treatment of inflammatory bowel disease, reflecting a shift in therapeutic philosophy. Aminosalicylates. Question: What is the role of sulfasalazine in the treatment of inflammatory bowel disease? Answer: Sulfasalazine is used primarily to treat colonic inflammatory bowel disease and was originally developed for arthritis. Question: What are the limitations associated with sulfasalazine therapy? Answer: The sulfapyridine component can cause sulfa allergies and necessitates folic acid supplementation. Question: How does sulfasalazine exert its therapeutic effect in the gastrointestinal tract? Answer: The sulfapyridine ring is cleaved to release 5-aminosalicylic acid, with different formulations targeting various regions of the gastrointestinal tract. Question: What is the advantage of multi-matrix technology, MMX, in aminosalicylate medications? Answer: Medications using multi-matrix technology are designed for once daily dosing and gradual release throughout the colon. Question: What treatment options are available for distal inflammatory bowel disease? Answer: Topical formulations are available for treating disease limited to the distal colon. Question: How are suppositories and enemas used in the treatment of mild to moderate inflammatory bowel disease? Answer: Suppositories and enemas are used for mild to moderate disease, with suppositories typically administered at bedtime and enemas targeting the rectum, sigmoid colon, and sometimes the left colon. Corticosteroids question. What is the role of corticosteroids in the management of severe inflammatory bowel disease? Answer. Steroids are effective, affordable, and widely available for the treatment of severe inflammatory bowel disease, despite their potential side effects. Question. What are the main side effects associated with corticosteroid therapy in inflammatory bowel disease? Answer. Side effects include a Cushingoid appearance, aseptic necrosis of the hips, hypertension, mood alterations, hyperglycemia, increased risk of surgical infections, cataracts, and striae. Question. When are biologic medications preferred over steroids in inflammatory bowel disease? Answer. Biologic medications are preferred when steroid side effects are a concern, although they are more expensive and require prothorization. Question. How should corticosteroids be used in the treatment of inflammatory bowel disease? Answer. They should be used sparingly and for the shortest duration possible, given the risk of complications and growth retardation in children. Question. What is the typical approach to corticosteroid dosing in inflammatory bowel disease? Answer. High doses are usually initiated and then tapered rapidly, either as outpatient pulse therapy or administered intravenously for hospitalized patients. Question. What are the common dosing regimens for corticosteroids in outpatient and inpatient settings? Answer. Outpatient pulse therapy often involves prednisone at 40 to 60 mg per day, tapered over several weeks, while hospitalized patients may receive 100 mg of hydrocortisone intravenously every 6 to 8 hours. Immunomodulators question. What are thiopurines, and how are they used in the management of Crohn's disease? Answer. Thiopurines are steroid-sparing agents used for Crohn's disease and in organ transplant patients, especially when steroid weaning has been unsuccessful. Question. What are the main side effects of thiopurines in inflammatory bowel disease patients? Answer. Major side effects include leukopenia and pancreatitis, primarily in individuals with a specific variant of thiopurine methyltransferase. Question. What are the advantages and disadvantages of thiopurine therapy? Answer. Advantages include oral administration, daily dosing, and wide availability, while disadvantages include a 3 to 4 month lag for therapeutic effect and an increased risk of non-Hodgkin lymphoma with long-term use. Question. What is methotrexate, and how is it administered in inflammatory bowel disease? Answer. Methotrexate is an immunomodulating medication that can be given orally or by intramuscular injection. Question. What are the main side effects of methotrexate therapy in inflammatory bowel disease? Answer. Side effects include elevated liver function tests, pulmonary fibrosis, and the need for folic acid supplementation. Biologic therapy question. What are biologic therapies, and how were they initially used in inflammatory bowel disease? Answer. Biologic therapies initially referred to monoclonal antibodies used as drugs for inflammatory bowel disease. Question. Which was the first biologic therapy approved for inflammatory bowel disease, and what is its mechanism? Answer. Infliximab, a tumor necrosis factor alpha inhibitor, was the first approved biologic therapy, introduced in 1998. Question. What are the main risks associated with biologic therapy in inflammatory bowel disease? Answer. Biologic therapy can reactivate infections such as tuberculosis, histoplasmosis, actinomycosis, and hepatitis. Question. What pre-treatment testing is recommended before starting biologic therapy? Answer. Pre-treatment testing includes a tuberculin skin test or quantiferin gold assay and a hepatitis profile. Question. What is the risk of lymphoma in patients treated with biologic therapy for inflammatory bowel disease? Answer. There is an increased risk of non-Hodgkin lymphoma and a small risk of hepatosplenic T-cell lymphomas, particularly in young males receiving combination immunosuppressive therapy. Question. Is there a reliable test for past exposure to histoplasmosis prior to biologic therapy initiation? Answer. No reliable test exists for detecting past exposure to histoplasmosis. Question. What new therapies have emerged for the treatment of inflammation in inflammatory bowel disease? Answer. New therapies include Janus kinase inhibitors, anti-alpha-4 integrins, and anti-interleukin agents. Question. What are Janus kinase inhibitors, and which are commonly used in inflammatory bowel disease? Answer. Janus kinase inhibitors, such as tofacitinib and upadacitinib, are used to modulate the immune response and reduce inflammation. Question. How do Janus kinase inhibitors work in the treatment of inflammatory bowel disease? Answer. They target the Janus kinase signal transducer and activator of transcription signaling pathway to modulate the immune response and reduce inflammation. Question: what are anti-integrin drugs, and what is their therapeutic role? Answer: anti-integrin drugs target cell adhesion molecules to reduce gut-specific inflammation without compromising systemic immunity. Question: how do anti-interleukin agents function in the management of inflammatory bowel disease? Answer: they specifically target interleukins 12 and 23 to modulate the immune response and reduce inflammation. Question: what is vedolizumab, and what is its mechanism of action? Answer: vedolizumab is an anti-alpha-4 integrin drug used to treat inflammatory bowel disease. Assessment of symptom severity. Question: how is disease severity assessed in patients with inflammatory bowel disease? Answer: severity is assessed using classification schemes such as the Truelove and Witts classification, which consider the severity of diarrhea and symptoms such as blood in the stool, fever, and tachycardia. Question: what laboratory markers are used to evaluate inflammation in inflammatory bowel disease? Answer: fecal calprotectin and lactoferrin levels serve as markers of inflammation and are used to monitor disease activity. Question: how is disease activity measured in Crohn's disease? Answer: the Crohn's Disease Activity Index and the Harvey-Bradshaw Index are used to quantify disease activity based on symptoms and laboratory findings. Question: what variables are included in the Crohn's Disease Activity Index? Answer: the index includes 8 clinical and laboratory variables, such as the number of bowel movements, abdominal pain, hematocrit, and weight loss. Question: how are Crohn's Disease Activity Index scores interpreted? Answer: a score less than 150 indicates clinical remission, while a score greater than 450 signifies severe disease. Question: what is the Harvey-Bradshaw Index, and how does it differ from the Crohn's Disease Activity Index? Answer: the Harvey-Bradshaw Index is a modification of the Crohn's Disease Activity Index that uses only clinical data and does not require a 7-day symptom diary. Indications for surgery for ulcerative colitis. Question: when is surgery indicated for patients with ulcerative colitis? Answer: surgery is indicated for patients who fail to respond to maximum medical therapy, including biologic therapies. Question: what are the typical symptoms in patients with severe ulcerative colitis requiring surgery? Answer: patients may experience multiple bowel movements, poor nutritional status, and require surgery to restore health. Question: what benefits does surgery offer to patients with severe ulcerative colitis? Answer: surgery can result in significant improvement in quality of life, particularly for those with symptoms such as urgency, tenesmus, and low body weight. Question: which patient group is most likely to require surgery for ulcerative colitis? Answer: patients with fulminant colitis who do not respond to maximum medical therapy are most likely to require surgery. Question: what is the recommended treatment for fulminant colitis in ulcerative colitis patients? Answer: hospitalization, intravenous steroids, and sometimes in-hospital biologic therapy or intravenous cyclosporine are recommended. Question: what is toxic megacolon, and how is it related to ulcerative colitis? Answer: toxic megacolon is a complication that may occur in ulcerative colitis, defined by the presence of 3 or more of the following criteria: tachycardia greater than 100, leukocytosis over 12,000 per deciliter, hypoalbuminemia less than 3 grams per deciliter, temperature above 38 degrees Celsius, or a transverse colon diameter exceeding 5 centimeters on abdominal radiograph. Question: how is toxic megacolon defined in the context of ulcerative colitis? Answer: toxic megacolon is defined by the presence of 3 or more criteria for fulminant colitis, though colonic dilation, megacolon, may not always be present. Question: what is the significance of gastrointestinal bleeding in ulcerative colitis? Answer: mucosal sloughing exposes blood vessels, which can lead to massive hemorrhage and necessitate urgent surgical intervention. Question: what are the surgical indications for ulcerative colitis in children? Answer: failure to achieve normal growth and the presence of dysplasia or cancer are indications for surgery in children. Question: what is the long-term cancer risk in patients with ulcerative colitis? Answer: patients with ulcerative colitis for more than 8 years have a high risk of developing dysplasia or cancer. Question: what surveillance is recommended for patients with long-standing ulcerative colitis? Answer: annual colonoscopic surveillance, with or without chromondoscopy, is advised for patients with ulcerative colitis of more than 8 years duration. Question: What is the recommended management for dysplasia detected in ulcerative colitis? Answer. Colectomy is recommended for patients with multiple areas of low-grade dysplasia or any high-grade dysplasia to prevent invasive adenocarcinoma. Question. How is dysplasia management determined in ulcerative colitis? Answer. Management depends on whether the lesion is visible and can be completely excised. Question. What is the preferred method for excision of visible dysplastic lesions in ulcerative colitis? Answer. Endoscopic excision is preferred, with en-bloc removal favored to allow for detailed histologic evaluation. Question. What is the risk following the removal of dysplasia in ulcerative colitis? Answer. There is a heightened risk of recurrent dysplasia, requiring close endoscopic surveillance and, in some cases, total proctocolectomy due to increased risk of colorectal cancer. Question. What is the recommended approach for patients with invisible dysplasia detected on random biopsies? Answer. Such patients should be referred to an experienced endoscopist for repeat high-definition colonoscopy with chromondoscopy and both targeted and repeat random biopsies within 3 to 6 months. Question. What is the recommended surgical treatment for confirmed invisible multifocal low-grade dysplasia or any invisible high-grade dysplasia in ulcerative colitis? Answer. Total proctocolectomy is typically indicated for these patients. Question. How have high-definition colonoscopy and chromondoscopy improved dysplasia detection in ulcerative colitis? Answer. These advanced endoscopic techniques have greatly improved the detection rate of dysplasia in patients with ulcerative colitis. Question. What are the types of dysplasia seen in ulcerative colitis, and how are they managed? Answer. Flat dysplasia is difficult to detect, while polypoid dysplasia is more apparent and can be treated like a conventional polyp. Question. How does polypectomy impact cancer risk in ulcerative colitis? Answer. Removal of dysplastic lesions through polypectomy during colonoscopy has been shown in some studies to reduce the risk of cancer development. Question. What factors are essential for successful management of dysplasia in ulcerative colitis? Answer. Success relies on meticulous colonoscopy, pathology expertise, and patient compliance with close follow-up. Question. When is colectomy indicated for dysplasia in ulcerative colitis? Answer. There is general agreement that colectomy is necessary for multiple areas of flat dysplasia within the colon. Question. How is cancer risk linked to chronic inflammation in inflammatory bowel disease? Answer. Approximately 20% of cancers worldwide are linked to chronic inflammation, and improved management of inflammatory bowel disease may reduce this risk. Question. What is the surgical indication for adenocarcinoma in inflammatory bowel disease? Answer. Colectomy is indicated for patients diagnosed with adenocarcinoma. Question. When may colectomy be considered for severe extraintestinal manifestations in ulcerative colitis? Answer. Colectomy may be considered for patients with severe extraintestinal disease, although its effectiveness can vary. Question. Does the course of extraintestinal disease in ulcerative colitis always depend on colonic disease activity? Answer. No. The course of extraintestinal disease can be independent of the colon. Indications for surgery for Crohn disease. Question. When is surgery indicated in Crohn's disease? Answer. Surgery is generally reserved for complications rather than being a primary treatment, as is often the case in ulcerative colitis. Question. What are the surgical indications for Crohn's disease in children? Answer. Surgery is indicated for children with Crohn's disease who fail to achieve normal growth, similar to the approach in ulcerative colitis. Question. For what reason is surgery most frequently performed in Crohn's disease? Answer. Surgery is most commonly performed for obstruction resulting from fibrostenosing Crohn's disease. Question. What other surgical indications exist for Crohn's disease? Answer. Indications include perforating disease with abscess or fistula, symptomatic ileal sigmoid fistula causing diarrhea, enterocutaneous fistulas, significant abdominal pain due to obstruction, and associated cancer or dysplasia. Question. Are all fistulas considered an indication for surgery in Crohn's disease? Answer. While many fistulas are a relative indication for surgery, enteroenteric fistulas are not unless they cause significant symptoms. Question. How is dysplasia managed surgically in Crohn's disease? Answer. Similar to ulcerative colitis, dysplasia in Crohn's disease may require surgery, with total proctocolectomy being preferable to segmental resection if dysplasia is multifocal. Question. What measures are taken to optimize patients with Crohn's disease prior to surgery? Answer. Antibiotics are used to control infection and reduce bacterial load. thereby lowering post-operative infection rates. Question: how are abscesses managed in patients with Crohn's disease prior to surgery? Answer: percutaneous drainage under radiological guidance is the first-line treatment for abscesses, improving the patient's condition and reducing septic complications. Question: why is preoperative nutritional support important in Crohn's disease? Answer: malnutrition necessitates preoperative nutritional support, such as enteral or parenteral nutrition, to enhance wound healing and immune function. Question: how should medication be managed preoperatively in Crohn's disease patients? Answer: biologic agents and corticosteroids may increase postoperative complication risks and require careful preoperative management, including discontinuation or tapering. Question: why are patients with Crohn's disease and ulcerative colitis at increased risk for deep vein thrombosis? Answer: inflammation leads to a hypercoagulable state, increasing the risk of deep vein thrombosis in these patients. Question: what is recommended to mitigate the risk of deep vein thrombosis in inflammatory bowel disease patients undergoing surgery? Answer: deep vein thrombosis prophylaxis should be initiated before surgery in these patients. Question: why is a multidisciplinary approach required in the preoperative care of inflammatory bowel disease patients? Answer: preoperative care involves collaboration among gastroenterologists, surgeons, radiologists, and dietitians to optimize patient outcomes. Surgical options for ulcerative colitis. Question: what surgical procedures are commonly performed for fulminant ulcerative colitis? Answer: subtotal colectomy, ileostomy, and Hartmann's procedure are frequently performed for fulminant disease. Question: what are the common elective surgical procedures for ulcerative colitis? Answer: total proctocolectomy with endoileostomy and proctocolectomy with ileal pouch anal anastomosis are commonly performed in the elective setting. Question: what are less commonly performed surgical options for ulcerative colitis? Answer: subtotal colectomy with ileal rectal anastomosis and total proctocolectomy with continent ileostomy are less frequently performed. Question: what is the standard surgical treatment for fulminant colitis? Answer: subtotal or total colectomy with ileostomy and Hartmann's procedure is the standard treatment. Question: what is toxic megacolon, and how does it influence surgical management? Answer: toxic megacolon is a condition where patients become toxic from colitis regardless of cause, necessitating prompt surgical intervention to prevent colonic perforation. Question: what symptoms are associated with toxic megacolon? Answer: symptoms include leukocytosis, tachycardia, fever, hemodynamic instability, protein-losing enteropathy, and hypoalbuminemia. Question: what are important surgical considerations in patients with toxic megacolon? Answer: gentle handling of the colon is crucial to avoid perforation, especially in cases of significant dilation or loss of domain. Question: how can Hartmann's stump blowout be prevented during surgery? Answer: leaving a long Hartmann's stump and incorporating it into the fascial closure can prevent pelvic abscess formation. Question: what is the management approach if stump dehiscence occurs postoperatively? Answer: a controlled mucus fistula can be created to avoid deep pelvic infection. Question: when can restoration of intestinal continuity be considered after colectomy? Answer: it can be considered after the patient is stabilized and immunosuppressants have been weaned, usually after 3 months. Question: what is the main advantage of ileal rectal anastomosis in ulcerative colitis surgery? Answer: this procedure avoids pelvic dissection complications by connecting the ileum directly to the rectum. Question: in which patients is ileal rectal anastomosis most appropriate? Answer: it is best suited for patients with limited rectal involvement, although this is uncommon in ulcerative colitis. Question: what post-surgical surveillance is required following ileal rectal anastomosis? Answer: continued surveillance for dysplasia is required due to an increased risk of cancer in the retained rectum. Question: what is the most popular surgical procedure for ulcerative colitis not responding to medical therapy? Answer: ileal pouch anal anastomosis is the most popular procedure for these patients. Question: what are the main advantages of ileal pouch anal anastomosis compared to ileal rectal anastomosis? Answer: ileal pouch anal anastomosis removes the entire colon and most at-risk mucosa. Question: what does the ileal pouch anal anastomosis procedure involve? Answer: it involves proctocolectomy and the creation of a small bowel reservoir from the terminal ileum, which is then connected to the anal canal or lower rectum. Question: What are the different reservoir configurations for ileal pouch anal anastomosis? Answer. Reservoirs include S pouches, W pouches, and H pouches, each with specific advantages and disadvantages. Question. Why is the J pouch configuration preferred in ileal pouch anal anastomosis? Answer. The J pouch is the simplest and easiest to create and is associated with the fewest complications. Question. How is the J pouch constructed during ileal pouch anal anastomosis? Answer. It is created using 15 cm limbs of terminal ileum and 2 firings of a gastrointestinal anastomosis stapler. Question. How is the apex of the J pouch attached during surgery? Answer. The apex of the J pouch is either stapled or hand-sewn to the distal rectum. Question. Why might temporary fecal diversion be required after ileal pouch anal anastomosis surgery? Answer. Patients on immunosuppressants or in poor nutritional state often require temporary fecal diversion for 2 to 3 months post-surgery. Question. When can ileal pouch anal anastomosis be performed in a single stage? Answer. Patients who are in good nutritional state and not on immunosuppressants can undergo single-stage surgery without fecal diversion. Question. How is temporary ileostomy closure usually performed? Answer. Temporary ileostomies are typically closed without a laparotomy. Question. What surgical techniques can reduce tension on the ileal pouch during ileal pouch anal anastomosis? Answer. Mobilizing the small bowel mesentery up to the pancreas level can reduce tension. Question. Why is preservation of the ileocolic vessels important during right colon mesentery division? Answer. Complete preservation of the ileocolic vessels is important to maintain adequate blood supply during surgery. Question. How is tension on the mesenteric vessels assessed during ileal pouch anal anastomosis? Answer. Distal traction is applied to the J pouch apex to assess tension on the superior mesenteric and ileocolic vessels. Question. What techniques can be used to extend mesenteric length during ileal pouch anal anastomosis? Answer. Mesenteric length can be extended by dividing vessels under tension or creating peritoneal windows by making slits in the peritoneum covering the mesenteric vessels. Question. How much additional length can peritoneal windowing provide? Answer. Peritoneal windowing can provide an extra 1 to 2 centimeters of mesenteric length. Question. What patient factors can make achieving sufficient mesenteric length more challenging during ileal pouch anal anastomosis? Answer. Obesity, height, and torso length can make it more difficult to achieve adequate mesenteric length for tension-free small bowel placement. Question. What are the main options for ileal pouch anal anastomosis creation? Answer. Surgeons can choose among 1-stage, II stage, and 3-stage procedures. Question. In which patients is the II stage ileal pouch anal anastomosis procedure preferred? Answer. The II stage procedure is favored for elective cases, especially patients without significant inflammation, and involves total proctocolectomy, pouch creation, and a temporary ileostomy. Question. When is the 3-stage ileal pouch anal anastomosis procedure indicated? Answer. It is reserved for patients with severe ulcerative colitis symptoms, beginning with total abdominal colectomy and culminating in pouch creation after a recovery period. Question. What are the 2 main types of anastomosis used in ileal pouch anal anastomosis surgery? Answer. The 2 main types are mucosectomy with hand-sutured anastomosis, which reduces recurrence but affects function, and the double-stapled method, which is faster but may increase recurrence. Question. What is the modified II stage ileal pouch anal anastomosis procedure? Answer. This involves subtotal colectomy with endoileostomy, followed by completion proctectomy and pouch creation without diverting ileostomy, resulting in a lower anastomotic leak rate. Question. What are the indications for the 3-stage ileal pouch anal anastomosis procedure? Answer. It is used for patients with acute colitis or those at high risk due to malnutrition or steroid therapy. Question. What are the common early complications following ileal pouch anal anastomosis surgery? Answer. Early complications include pelvic sepsis, fistulae, sinuses, and strictures. Question. What are the late complications associated with ileal pouch anal anastomosis? Answer. Late complications include Crohn disease, especially in patients with emergent colectomy or indeterminate colitis. Question. How many bowel movements do patients typically have after ileal pouch anal anastomosis? Answer. Patients typically experience up to 6 bowel movements per day, including 1 at night. Question. How does the function of the ileal pouch change over time post-operatively? Answer. By 6 months, The pouch enlarges significantly, reducing the need for antidiarrheal medication. Question: what are the main reasons for redo ileal pouch anal anastomosis surgery? Answer: redo surgery may be needed due to technical challenges from the initial operation or inflammatory complications such as pelvic sepsis. Question: what are the outcomes of redo ileal pouch anal anastomosis surgery? Answer: approximately 41% of patients require a new pouch, while 59% undergo pouch revisions, with some experiencing complications such as anastomotic leaks. Question: what is the success rate for redo ileal pouch anal anastomosis surgery? Answer: around 21% of patients experience failures, but many report improved functional outcomes and quality of life. Surgery for Crohn disease. Question: what is the main indication for ileocolic resection in Crohn's disease? Answer: ileocolic resection is commonly performed for patients with fibrostenosing disease causing obstruction or fistulizing disease. Question: what complications can arise from obstruction in Crohn's disease? Answer: obstruction and proximal perforation can cause abscess formation, which may result in the development of an ileosigmoid fistula. Question: why is the ileocecal region often involved in Crohn's disease surgery? Answer: the ileocecal region is frequently affected and often requires ileocolic resection. Question: is ileocolic resection suitable for laparoscopic surgery in Crohn's disease? Answer: yes, except in cases with extensive fistulizing disease or significant phlegmon. Question: how should resection margins be selected during surgery for Crohn's disease? Answer: surgeons should select bowel segments that feel normal, are not thickened, and have a normal mesenteric junction. Question: why is it important to document residual bowel length during surgery for Crohn's disease? Answer: documenting residual bowel length is crucial, as up to 50% of patients may require additional surgery within 10 years. Question: what is the most popular type of anastomosis for Crohn's disease surgery? Answer: the stapled side-to-side anastomosis is most commonly used. Question: what is the Cone-OS anastomosis, and what are its benefits? Answer: the Cone-OS anastomosis is a functional end-to-end, side-to-side, hand-sewn anastomosis using a non-cutting linear stapler, which creates a wide, anti-tension, anti-angulation connection to enhance flow and prevent fecal stasis. Question: what were the findings of the Supreme Crohn disease trial regarding Cone-OS anastomosis? Answer: the trial found that Cone-OS anastomosis significantly reduced both endoscopic and clinical recurrence rates compared to conventional side-to-side anastomosis. Question: is Cone-OS anastomosis associated with increased surgical risk? Answer: no safety issues were observed in the trial. Question: what did larger studies reveal about recurrence rates with Cone-OS compared to traditional anastomosis? Answer: a larger-scale study found comparable rates of endoscopic recurrence between Cone-OS and traditional side-to-side functional end anastomosis. Question: how are Cone-OS anastomoses managed post-operatively? Answer: they are easy to evaluate endoscopically and can be dilated if recurrent disease develops. Question: how wide should the anastomosis be constructed in Crohn's disease surgery? Answer: the anastomosis should be made as wide as possible, regardless of the construction method. Segmental colon resection and other surgical options. Question: what is the trend regarding segmental colonic resection in Crohn's disease management? Answer: segmental colonic resection has become increasingly common in the past 2 decades for Crohn's disease. Question: what is the rationale for performing segmental colonic resection in Crohn's disease? Answer: the rationale includes the colon's role in water absorption and the availability of more effective medications for managing the disease. Question: what does segmental resection involve in Crohn's disease surgery? Answer: segmental resection removes the diseased portion of the colon while preserving healthy tissue. Question: who is an ideal candidate for segmental colonic resection in Crohn's disease? Answer: patients with isolated colonic strictures and normal-appearing segments of colon are ideal candidates. Question: what is the recommended post-operative management following segmental resection in Crohn's disease? Answer: chemoprophylaxis is recommended to minimize the risk of disease recurrence. Question: when is subtotal colectomy with ileorectal anastomosis indicated in Crohn's disease? Answer: this procedure is preferred for patients whose rectum is relatively spared but who have a diseased colon. Question: what are the recurrence rates following subtotal colectomy with ileorectal anastomosis in Crohn's disease? Answer: there is a higher recurrence rate compared to other procedures. Question: What are the postoperative options for patients undergoing subtotal colectomy in Crohn's disease? Answer. Options include ileal pouch rectal anastomosis to reduce bowel movements, which may require temporary fecal diversion. Question. When is proctocolectomy with ileal pouch anal anastomosis considered for Crohn's disease? Answer. It is increasingly considered for patients without perianal disease who are well informed about the increased risks and less favorable outcomes compared to ulcerative colitis patients. Question. What are the risks associated with proctocolectomy and ileal pouch anal anastomosis in Crohn's disease? Answer. Risks include a higher likelihood of fistulizing disease, need for conversion to endoleostomy, increased bowel movements, and greater morbidity. Cancer risk in inflammatory bowel disease. Question. What is the risk of colon cancer in patients with long-standing Crohn's disease? Answer. There is an increased risk of colon cancer, although it is lower than that seen with ulcerative colitis. Total colectomy is recommended if cancer is detected. Question. What is the risk of small bowel cancer in Crohn's disease? Answer. Small bowel cancer is a rare but serious complication, especially in those with long disease duration, extensive small bowel involvement, prior surgical resections, or a family history of colorectal cancer. Question. How can the risk of small bowel cancer in Crohn's disease be managed? Answer. Regular monitoring and early detection are crucial for effective risk management. Postoperative complications. Question. Which inflammatory bowel disease patients are at greatest risk for postoperative infections? Answer. Patients on immunosuppressive medications and those with hypoalbuminemia are at increased risk for postoperative infections. Question. How do steroids affect postoperative risk in inflammatory bowel disease? Answer. Steroid use generally increases the risk of postoperative infections. Question. What do large studies suggest about the risk of postoperative complications with biologic therapy in Crohn's disease? Answer. Large studies indicate that biologic therapy does not significantly increase the risk of postoperative complications in Crohn's disease patients undergoing abdominal surgery. Question. Is it mandatory to stop all medications before surgery in inflammatory bowel disease patients? Answer. It is not mandatory to discontinue all medications prior to surgery. Question. What is the risk of venous thromboembolism following surgery in inflammatory bowel disease patients? Answer. There is a significantly increased risk of venous thromboembolism after surgery, even after accounting for factors such as smoking and body mass index. Question. What postoperative care is necessary to reduce venous thromboembolism risk? Answer. Vigilant postoperative venous thromboembolism prophylaxis is essential. Postoperative recurrence. Question. What methods are essential for postoperative surveillance in Crohn's disease? Answer. Clinical follow-ups, fecal calprotectin monitoring, and endoscopic investigations are vital for early detection of recurrence. Question. When is endoscopic assessment recommended following Crohn's disease surgery? Answer. Ileocolonoscopy within 6 to 12 months after surgery is recommended to identify endoscopic recurrence, which often precedes clinical symptoms. Question. What is the Rutgerz score, and how is it used? Answer. The Rutgerz score is a grading system for endoscopic recurrence that helps guide the intensity of treatment, with a score of I2 or higher indicating the need for more aggressive therapy. Question. What lifestyle changes are recommended to reduce postoperative recurrence risk in Crohn's disease? Answer. Lifestyle modifications, particularly smoking cessation, are recommended. Question. What is the role of biologic therapy in postoperative prophylaxis for Crohn's disease? Answer. Biologic agents are often used as first-line prophylactic therapy, especially in high-risk patients. Question. How important is nutritional support in the prevention of postoperative recurrence in Crohn's disease? Answer. Nutritional support is an important component of preventative care. Perianal Crohn disease. Question. What is the prevalence of anorectal fistulas in Crohn's disease? Answer. About 40% of Crohn's disease patients develop anorectal fistulas. Question. What is the recommended approach to treating perianal Crohn's disease? Answer. A multidisciplinary approach combining surgical and medical interventions is recommended. Question. What are the main goals of treatment for perianal Crohn's disease? Answer. The main goals are to control infection and manage the underlying Crohn's disease. Question. What is the purpose of the Perianal Disease Activity Index in Crohn's disease? Answer. The Perianal Disease Activity Index quantifies the severity of perianal disease in Crohn's disease patients. Question. What components are included in the Perianal Disease Activity Index? Answer. The index considers the number and type of active fistulas, pain intensity, impact on daily activities, and overall well-being. Question. How is the Perianal Disease Activity Index used in clinical practice? Answer. It is used to monitor disease progression and evaluate the effectiveness of treatment. Question. What is the efficacy of biologic therapy in treating fistulizing perianal Crohn's disease? Answer. Infliximab achieves fistula healing rates up to 60%, while other biologics such as adalimumab and certolizumab have success rates of 50 to 55%. Question. How effective are immunosuppressants in treating perianal Crohn's disease? Answer. Immunosuppressants like azathioprine and cyclosporine have a success rate of approximately 30%. Question. What has become the mainstay of medical management for perianal Crohn's disease in recent years? Answer. Biologic therapy has become the mainstay of medical management over the past decade. Question. What is the success rate of draining signes in perianal Crohn's disease? Answer. Draining signes have about a 70% success rate in controlling infection and promoting healing. Question. How is fistula surgery approached in Crohn's disease? Answer. Surgery is highly individualized, considering symptom severity, fistula tract anatomy, and Crohn's disease status. Question. What proportion of Crohn's disease patients require further intervention after fistula surgery? Answer. Nearly 25% require additional interventions due to complications such as non-healing wounds or recurrent fistula. Question. What is the efficacy of antibiotic treatment for perianal Crohn's disease? Answer. Antibiotics, especially metronidazole and fluoroquinolones, provide symptom relief in 80% of patients when drainage is not the primary issue. Question. How common are asymptomatic fistulas in Crohn's disease, and how are they managed? Answer. Approximately 15% of patients have asymptomatic fistulas, which can remain dormant for long periods and are generally managed conservatively to avoid unnecessary surgical risks. Question. What are the treatment recommendations for severe, refractory perianal Crohn's disease? Answer. Proctectomy and permanent fecal diversion are considered in less than 5% of severe, refractory cases. Question. What emerging treatment shows promise for refractory fistulizing anorectal Crohn's disease? Answer. Local administration of mesenchymal stem cells has shown a 65% success rate in preliminary clinical trials. Question. What are the long-term outcomes of mesenchymal stem cell therapy in perianal Crohn's disease? Answer. Long-term outcomes are lower than initial results, with 56% achieving clinical remission at 2 years. Question. What was the name of the Phase 3 randomized trial investigating mesenchymal stem cells in perianal Crohn's disease? Answer. The trial was called Admire Crohn disease. Question. What hope do mesenchymal stem cells offer in the treatment of perianal Crohn's disease? Answer. Mesenchymal stem cells offer hope for patients who have exhausted other treatment options. Question. What challenges are associated with the use of mesenchymal stem cells in perianal Crohn's disease? Answer. Treatment often requires multiple applications and is associated with significantly increased costs. Infectious colitis. Question. What is the definition of ischemic colitis? Answer. Ischemic colitis is a common disorder caused by insufficient blood supply to the colon. Question. What is the most common form of gastrointestinal ischemia? Answer. Ischemic colitis is the most common form of gastrointestinal ischemia. Question. What are the incidence rates of ischemic colitis? Answer. Rates range from 7.1 to 22.9 per 100,000 person-years. Question. How severe can ischemic colitis be, and is the incidence likely higher than reported? Answer. Ischemic colitis severity ranges from mild to life-threatening, with a likely higher incidence than reported due to nonspecific symptoms. Question. How does ischemic colitis differ from acute mesenteric ischemia? Answer. Unlike acute mesenteric ischemia, which involves major vessel obstruction and severe pain, ischemic colitis affects smaller vessels and presents less dramatically. Question. Why is prompt diagnosis and treatment of ischemic colitis important? Answer. Prompt diagnosis and treatment are crucial, as delays can lead to emergency colectomy with high morbidity and mortality. Anatomic considerations. Question. From which arteries does the colon receive its blood supply? Answer. The colon receives blood from the superior mesenteric artery and the inferior mesenteric artery. Question. What are the branches of the superior mesenteric artery? Answer. The superior mesenteric artery branches into the ileocolic, right colic, and middle colic arteries. Question: what are the branches of the inferior mesenteric artery? Answer: the inferior mesenteric artery branches into the left colic and sigmoid arteries, and ends as the superior rectal artery. Question: how does the marginal artery of Drummond contribute to colonic blood supply? Answer: the colon receives collateral blood supply through the marginal artery of Drummond, which is crucial to preserve during colon resection to prevent ischemia. Question: what is the arc of Riolan and what is its clinical significance? Answer: the arc of Riolan, or meandering mesenteric artery, connects the superior and inferior mesenteric arteries and can provide collateral circulation in cases of major mesenteric artery occlusion. A large arc of Riolan often suggests an obstruction in one of the major mesenteric arteries. Question: what are the watershed areas in the colon and why are they significant? Answer: watershed areas are potentially ischemic regions at the edges of the superior and inferior mesenteric artery supply zones, reliant on collateral circulation. Question: what is Griffith's point and its clinical significance? Answer: Griffith's point at the splenic flexure is a watershed area with potentially inconsistent collateral circulation, often lacking a marginal artery, making anastomosis risky. Question: what is Sudeck's point and why is it important? Answer: Sudeck's point at the rectosigmoid junction is another watershed area vulnerable to ischemia. Question: what arteries supply blood to the rectosigmoid region? Answer: the region receives blood from the superior hemorrhoidal artery and distal sigmoid branches, both branches of the inferior mesenteric artery. Question: why is the right colon susceptible to ischemia? Answer: the right colon is susceptible to ischemia from embolic occlusion and low flow conditions due to its blood supply from the terminal branch of the superior mesenteric artery. Question: why is the rectum less prone to ischemic injury? Answer: the rectum has a robust blood supply from both the inferior mesenteric artery and iliac circulation, making it less prone to ischemic injury. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.